Welcome to the Friends of NPACE Podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Welcome, everyone, to the Friends of NPACE podcast. I'm so excited to have you here because we're continuing on our APP Entrepreneur journey, and I have two amazing guests, and I will try not to have fangirl moments with both of them. I'm super honored to have them here. First, Dr. Wendy Wright, you are a powerhouse in the NP world. You're a founder and owner of a thriving NP-led clinic in New Hampshire, and you have numerous awards for excellence, growth. You also lead Duet Technologies, and that's why Jonathan is here. You're the Chief Clinical Officer, helping other NPs launch and run successful practices. You are behind the Partners in Healthcare Education, and you started the New Hampshire Chamber of Entrepreneurial Nurse Practitioners to support NP innovation. You have decades of experience. You've been named one of the top NPs in America, not once, not twice, but multiple times. Honored as a top 100 scholar by the University of Alabama. You're also an author, speaker, one of the best educators I know. You consult. I don't know how you have time to sleep. You have a best-selling book called, I know, do you sleep?
I do sleep. Sleep is really important to me. I am not a good human if I don't sleep. But that sounds really cool. Thank you for putting that bio together.
Well, I haven't read your book yet, Breaking the Cycle, but I know we did a podcast a little bit on your journey. So that's next on my reading list. And you empower NPs wherever you go to lead and grow and thrive. And I appreciate you being here because I know your time is precious. And joining Wendy and all of us here is Jonathan Goldberg. Jonathan, you are the founder and CEO of Duet, a fast-growing platform. You help nurse practitioners launch and scale independent clinics. Under your leadership, Duet's network now supports over 250,000. I got that right, patients, nationwide, named one of the top 50 startups to watch in 2025. Jonathan, your passion is for social impact, and that's shaped your career from early work with Teach for America. I didn't know you were a Teach for America person, to building social impact arm at D.E. Shaw. You're also a partner at Squad Capital. That's an investing tech that improves everyday life for people, which we love. And you were a founding exec at, I'm going to say this wrong, Notel. Did
Perfect.
I say that?
Yeah.
Okay. Scaling globally before it was acquired. You are a Fulbright scholar. Oh, I love that. And you hold a degree from Columbia and Cambridge, all over the place. And you just moved from the West Coast to the East Coast. And we were just talking about pets before we started and how that's been. Jonathan, did I miss anything?
Everything I do is to get a little bit closer to Wendy.
Well,
I'll tell you,
all of us are.
He's a great leader. It's truly an honor to stand alongside him. He's doing great things with us. So
I love that. I love what both of you are doing. And I feel it deeply when I'm with both of you, the passion and commitment, it just kind of radiates from you. And so that's why I asked you to be here. Thank you. All right. I want to start at the beginning. So Wendy, I'm going to start with you. You've owned your own practice a long time. Why? Why did you do that originally?
yeah, it was never truly in my plan, to be very honest with you. And I would have stayed in my job for the rest of my career. I was job sharing with an amazing nurse practitioner. It was her and me and a physician. And I loved my job until I didn't. And until the things that were happening at that clinic were things I couldn't overlook and really had no power to change, despite speaking up on multiple occasions. So I resigned, not having any plans. I was speaking already. I was already working with NPACE. I was already writing and teaching the board review. And I thought, I'm going to be a mom. I'm just going to take care of my kid. I'm going to take some time off. I'll figure out the next phase of my life. My sister was running a surgical clinic for a group of urologists. And she said, listen, I have the best idea. I'll leave them. I'll come help you open. You're the oldest sister. You'll pay for everything, but I'll work for you for the rest of my life. And come on, let's do it. I said, absolutely not. And so she hounded me. And 6 weeks later, we opened. It was so interesting. It was like a drug deal. I met the insurance executive in the parking lot on New Year's Eve to submit my credential. She's like, I'll meet you there at 9. I'm going out. I'm like, oh my goodness. You know what? Looking back, it was truly meant to be, because every place we turned, everyone had my back. And even the person who I rented the building from, I said, I can't afford 6,000 square feet. He said, pay me what you think you can afford, and you can have the space. And I know you're going to be fine. So when you think you can pay more and you think you're ready to buy the building, just tell me what you're willing to pay. So I think people recognized, and I just felt like it was the time. And so we opened with 7 patients in 2007, and we're at 6,500, and we're growing 150 new patients a month. So that's kind of the story, and had really no intentions, but things happen the way that they're meant to happen, I believe. And I even had nurse practitioners who had already done it reach out to me and say, listen, if you want to do this, you can have some of my space. Don't pay us rent, just get yourself going. So this is what Jonathan and I really want to bring to the nurse practitioner table. And that's really why we're here, is because there was such good graces when I opened that, but there weren't a lot of organizations to support me. And so that's why we're here today doing what we're doing at Duet, to help NPs and help pave the way for those clinics to open, but more importantly, sustain, because you can open, but to keep it going is really hard. And I've lived that. My mom cleaned our toilets. I cleaned our toilets. We scrubbed our own floors. We did what we had to do to stay open, and I wouldn't change that, but I wish it were a little bit easier. And that's what we're trying to make it a tad easier for NPs.
Do you think that was the biggest obstacle, that financial, that would be the thing that scares me the most?
It's scary as heck. For me, I was truly blessed in that I already had another career. Right. So speaking for me, I had already gone to a part-time job, and my job, I loved it so much, but it truly didn't pay much. It was my charitable contribution to society, because there was just never any raises. I didn't get a raise in, 15 years of working alongside him. It was okay though. I didn't need it. I had another career. So for me, it was a little bit easier in that, yes, I was losing some money from my NP world, but I knew I could make it up on the back end with speaking and, consulting and all of the gigs that I was doing. That's very different than a lot of nurse practitioners. I've always really been the breadwinner in our family. And so I needed, and many NPs are, right? And they don't have that second career that gives them additional income. So for me, I was lucky. I didn't necessarily need a salary, but I wanted to be paid for the work that I was doing at some point, as everyone does.
Yeah, absolutely. Jonathan, how did you become interested in NP-owned practice? That seems like such a far stretch from technology and innovation.
It came from such a strange place, but that's how sometimes good ideas just hatch. It was my wife. My wife had been going to primary care for a while, like anybody would, but she would come home, and I remember her coming home and saying how much she loved her NP. And, at first you hear about it and you kind of just pass it off as just another interesting thing that happened that day. But when you hear it a lot, it makes your ears perk up, especially if you're like me, you come from investing and building companies. It's always better to have 100 people that are super passionate about you than thousands that kind of know you and don't care. And so I just listened a little bit closer to understand, what is it, that makes her talk about it so much, to feel connected. And I had been building companies for a while and was interested in social impact. And so it really just started a journey for me to meet as many NPs as I could, to understand what is it that makes it so special, that my wife is really passionate about it. And it was a year. I really spent a year just researching, because before you throw yourself into something, I am obsessive. especially when it comes to building something. You really want to know what you're in for. And that's how I found my way to Wendy. I must have knocked on hundreds of doors of people. Many did not answer, understandable. Who's this weird guy asking me about why I'm an NP? But some were really, really gracious. I remember I met Lynn Rapsilber at NNPen and Lorraine and Sandy, and it was through them that they said you should talk to Wendy. Now, good luck trying to get Wendy on a call because we just went through her bio. There's no time.
I had no idea who he was. And he's like, let's meet for coffee and conference. And I was really like, really? Okay, I'll try to make it work. But I had no idea. And, I often will say people pick my brain, and I don't mind that. But there are days I'm picked out and I don't want to have my brain picked sometimes. And so I didn't meet him at the conference. We didn't connect for whatever reason. And then he kept like, hey, I really want to chat with you. So, and after we met, it was like, oh my goodness, this is what I have been trying to do in New Hampshire. And I think there were ideas that were coming up that you had come into the table with. But as I shared with you my journey of starting the New Hampshire Chamber of Entrepreneurial NPs, because I wanted an organization to support those of us who wanted to do this. And then Jonathan and Charlie came to my clinic. And I think that's where we really kind of kicked off. And it's changing every minute. The work we're doing, it was really set out to just support NP clinics. But now it's like, let's help you start. Let's help you scale. Let's help you contract. Let's help you bill. And it's just so much more. And it's evolving because NPs are saying to Jonathan and I, we need help. We don't know what we don't know. Can you tell us what insurances to get? Or, those are the things that have really evolved, which has been really fun to watch this.
I love this. I love that. Look, if you sold this to Wendy, right, Jonathan, you've got something really amazing.
Yeah. Well, the best part was not trying to sell her, because if I tried to sell her, she gets sold all the time. I was really just wanted to learn from Wendy. And honestly, today and most of the days we learn from Wendy, we learn from most of the NPs we work with. And that's how we try to build what we do, is to solve a problem and try to be along for the ride.
I love that. So well, I'm not going to ask you how many owners. How do people find you? How do you start with them? Are they own practices? Are they just curious? What's the path for someone with Duet?
At first we were looking to meet people who own practices, because that's how we were going to learn from Wendy and people like Wendy who live it. They are going through the motions of getting paid less for the same work. That was one problem that we immediately understood, which is it's unequal pay for equal work. And that kind of translates into how a practice is run or not run. So we started to work with NPs in New Hampshire that we met through Wendy, who were all going through the same motions of trying to make it work with less pay and the same costs as another practice down the road. And as that started to happen, it's word of mouth. People trust each other. And so we just started to get calls from people who are saying, what, I want to open. Do you think you can help us open? We didn't set out to do that. But once we started to learn from so many people who actually operate a practice, it put us in a spot to say, okay, here's what we learned. Don't do this. Don't do the things that people have learned that don't work. Don't spend a lot of money on stuff that you're never going to use. But it was a real trial and error process for us to start to work with people on the way up, just like you started to work, as we did at the beginning, with people who are already there and keep optimized. And now it's everybody. It's people who are launching. We have a special program for people who launch, and people who are growing. They're not done. They have more people they want to serve and just need some extra tools to overcome what is a system not built really around an NP model yet.
I think, and Jonathan hit the nail on the head. Once we started getting that momentum, the NPs would say, hey, I have a friend in Massachusetts who's doing this. And then every time myself and Dr. E go out on the road and we speak, that we have a website, so people start to find us that way. And, it just becomes kind of this this self-sustaining and growing model, representing hundreds of NP clinics now across the nation. And so we're picking up in, we've got people now in many, many states around the country. But as you can imagine, this is not easy because there's no organization that knows NPs even exist in their own ownership, including some of our national organizations. There's no database, but we're creating one. And we know that there's over Jonathan, over 4,500 or so NP clinics around the nation. We have a map built of where they all are. And these are clinics that have one NP. These are clinics like mine who have 11. And so trying to figure this all out has become, one of the things we want to do, because we want a database so that we can study the quality, so that we can go to insurers and say, listen, we've got, and Jonathan and the team will take our map and go out to these insurers who say, why would I want to sign with NPs? Well, because these are the practices in primary care, in psych, where there's such a need, and we're representing those practices. We have them all at the table, and they're ready to work with you, insurer, to provide care for your patients that have no access to this care. But, insurer, we want you to pay comparable rates. And Jonathan, maybe you could just quickly tell Terry, we've had some huge wins.
I want to hear
contracts.
Yeah. This is the part that, first of all, it's very easy to back NPs. This is the easiest and most difficult thing I've ever done, because you root for people every day who are doing the work and don't get credit, right? It's like a very easy group to want to just go well beyond to support, but the system doesn't see them. The system just doesn't see the quality or the number. And so when we go to an insurer and we can show it, insurers will say, this makes sense. And so one insurer is paying NPs more than they pay MDs. It's the first time we've ever encountered this. They know the quality is there. They know the passion for serving, especially the underserved, is there. No one else is coming. There's no cavalry coming of other people into the space. MDs have left. And so the insurers have signed deals with us that are paying NPs more than MDs. They're paying NPs for the quality of the work. So if you do well, you get a share of the savings, which was never allowed before for NPs. NPs were always employed and never saw that money. It went to somebody else. And so we ask for parity, but we start with greater. We have a much greater hill to overcome. And if you want to see a future where there's more independent care, then you need to honor the people that are doing the work. And I'll tell you, there's one thing that people often misunderstand, and it's like buried in the math. This legacy of you want to pay a discount. Only 85%, that's what you pay an NP for the same care as somebody else. And some will say that's justified by different path to practice and different schooling. What's the big deal? It's just 15%. But when you own your own practice, it's not 15%. If you were to pay somebody $100 for a visit with a patient, and an MD who's getting all $100 but has $70 of expenses, they'll make $30. So that's fine for them. But if you pay an NP not $100, $85, and they have the same expenses as an MD of $70, they only make $15. So 30 is twice as much as 15. It's a 50% difference, not 15. And so it's why it's so hard to grow a practice when the money at the top is unfair. It's just not equal. And so who knows, a 1 provider practice could be a 10 provider practice if they got paid fairly. And insurers are all at the table. They know there's no future without NPs, and they know there's no future if everyone ends up at the hospital for something that could have been prevented.
Right.
It just takes time and a hell of a lot of arm wrestling to get to that place.
Because there's no one place, Terry. We have to march in every state, talk to every decision maker in that state. And the insurers don't want people working for large institutions. They want to have providers stay independent because they often pay a facility fee, which is 3 times what we get paid in private practice. And I think a lot of this work around pay started in New Hampshire when I knew, because I know the providers down the street were getting 2 times or more what I was getting for doing the same work, both of us independent, but one was physician-led, one was NP-led. There's a law in New Hampshire that says insurers must publish. It's called a right to know law. Every fee you pay for every provider and every service is public domain, but they embed it in ways that no one ever can find it, and it's just undecipherable. Well, you know what? We deciphered it. The team at Duet, I call them our geeks, but they do such crazy, amazing work. They were able to pull all of this and say, if you're a physician in an independent practice, this is what this insurance pays you for this level of service. But if you're an NP, this is what you get. And all the NP owned clinics in the state of New Hampshire were in the bottom 1/3 of the payouts. And that's not fair. If I'm doing the same work, as a friend of mine in New Hampshire said, you don't need to be an astronaut to fly a damn airplane, right? That if I have education and I'm able to do the work, you're paying for service, you're not paying for a title. And so we use that. In fact, Jonathan and I worked to write testimony in New Hampshire for parity, using the numbers that the insurance company published, that they claim that they pay NPs what physicians get paid. No, they don't. No, they don't. And it's public domain. So these are the things that we work behind the scenes to try to make it a level playing field. Listen, you don't have to pay me more, but equal work for equal pay. If my quality scores are as good as yours, and I hold my clinic to that, then I want you to pay me what you're paying the providers down the street.
I think that's only fair. Oh, this is also exciting because you're right. Nobody was doing this fighting for us or gathering the data. Before we even started here today, we talked a little bit about how low the national numbers are on anybody that's even tracked it. In some places, there's no data for NPP-owned clinics. And then we got off, we'll talk about this tangent toward the end, but there's no data for PA-owned clinics at all anywhere, and we know they exist. Access to care is the name of the game, right? And so I know, Wendy, that you practice specifically for that reason. So do I. It's a core value.
Absolutely.
And why I choose to see the patients I choose, and the Medicaid and the states, and the venue for providing that care. And it sounds like that's a core value for Duet also.
It is a core value.
Yeah. Yeah. You know, I came from education at Teach for America, and it was, people would say that teachers have to fight the fight just to fight the fight. In other words, like, it's hard enough to be in the classroom and teach in areas that don't have a lot of infrastructure for students, but teachers don't even get paid fairly. So they have to now go buy the books and buy the additional equipment just for the kids. So you have 2 battles just to get to the starting line of doing the work you want to do. And it felt so similar as we met NPs in Mississippi and Texas and Oklahoma and Florida and all these communities where they just want to practice. They just want to take care. They are doing what my wife was feeling, was like, they see me and they listen to me and they honor who I am as a person, but they have to fight the fight just to get to that place. And like Wendy said, we're not trying to make it easy, because it's not easy to do this work, but it should be easier. And it should be fair. And if we can just do that, whatever those numbers are today, 3%, 5%, who knows, how much greater can it be when you don't have to do it backwards and uphill?
Right.
Yeah. I had no idea the insurers prefer independent practice over large health systems. It just seems to me that the big systems are buying all the practices.
They are, but that's not because the insurers want that to happen. They're buying the practices because every time they bring a provider to the table in a large system, there's about $1 million in ancillary services that are ordered up in that institution.
Wow.
So, and I was offered a buyout. I know this deal because the physician who wanted to buy me out at a large hospital said, Wendy, we love you. I want all 11. I think I even had 12 NPs at the time. We want them all because you'll expand our primary care. We know you'll never make money for primary care because primary care never makes money, but we want you because we want access to care. And we know you're going to keep everything in house. This is why they are buying everything up now, because primary care is a money-making entity. Ask large organizations who have purchased these huge primary care networks or started them up and then dissolve them because they don't make a lot of money. Listen, Terry, I never, ever became an NP to make a lot of money. My first NP contract was $40,000 a year. I mean, I went into this because I wanted to take care of people, and I continue to take insurance because I don't want to be one of those providers. And listen, I respect everyone's right to do what is right for them. I will never cast an aspersion on, on someone, but I want to take care of the haves and the have-nots. And I want people who have, state Medicaid plans to have access to really good care. And that is what I will go out with. When this career looks to be at its end, I will know I can put my head on my pillow and know that I took care of the most wealthy people in my community the same way I took care of people who are fighting to eat every day.
I appreciate you sharing that. And I feel that deeply. None of us become nurse practitioners to get rich, but we do want to take care of patients. And I love.
And we want to be paid for the work that we are doing, and fair salaries, right? And fair reimbursement.
Yep, because we have to eat too.
Totally. And no one needs to worry about payroll every 2 weeks, right? Like if you're worrying about payroll, how much time can you spend worrying about what you really want to focus on?
That is scary. That's a scary part. I mean, my payroll, I know it doesn't sound a lot when you look at, these big clinics, but for me, we're at $75,000 every 2 weeks for payroll. And that's just payroll. That's not benefits. That's not rent. That's not supplies. That's not the $50,000 a month American Express bill. This is just payroll. And so, what I say and what I testified to with Jonathan when we were talking about parity is every dollar we make goes back to providing employment. We're a tax base. We pay taxes, and so do our employees. And we're up to 31 who are contributing. And many of these employees are single moms, and they're trying to provide for their kids as medical assistants, as nurses. And you know what? Allow me to do that and allow us to contribute and take care of these patients by paying us fair salary or fair wages for the work that we're doing.
I appreciate that. I did interview Dr. E in this series. She's going to kick it off just talking about just do it in the imposter syndrome and not just making it too complex. But she said exactly what you said, Wendy. She said, I have a lot of females in my practice who are trying to provide for other people. And she said, I have a washer and dryer on site, so they can bring their laundry and do their laundry at work. She said, I make sure everybody stops for an hour and eats. But she said, we got to be able to pay people also within this model of taking care of people. Yeah. Do you think finances are the biggest scary monster in the room for NPs, whether they're starting or?
Yeah, I think that's one of them. I think Dr. Jan Towers said years and years ago, and we all knew and loved Dr. Towers and do love Dr. Towers, who really paved the way for AANP to even exist. But she talked about the reasons that NPs don't open or that they're so fearful, and it's certainly money. And it's also laws and regulations, because a lot of us don't know what we don't know. And I often say I will never wear orange and stripes because I did something intentionally. I'll wear orange, and that is not in my color wheel. I'm an Alabama grad, so we wear red. But in any event, it's because we didn't know. And so people really fear those regulations and taxes and setting up that whole structure. We get a lot of questions about that, don't we, Jonathan, in terms of
so many. Yeah. It's almost never the clinical side, right? The average, I think, experience level in our network is 10 years. Wow. That's how long people have been practicing. And that's not an issue. This is why they want to do it. But when you get down to, okay, I don't want to talk about money out loud because I feel bad talking about money, but I need to pay myself and replace a salary. What am I going to earn? Well, 50 states have 50 different payment structures, and each plan in every state is its own. So you start from a place of it's no one knows. And then you wonder what your expenses are going to be. So there's so much friction and uncertainty to start. Wendy, I haven't even showed you this yet, so you'll see it soon. We just built a calculator based on all the information that we have on all of these things. What are your expenses? So that you don't need months and consultants, and you can just click what I want to earn or how many patients I want to see, and in 3 seconds, it will spit out for you.
Goodness.
If you're in Florida and you want to do house calls, you want to see Medicare patients, this is what you should expect you're going to need to see in terms of patients to make the amount of money you want. And these are your expenses. So this is the useful thing of when he calls us geeks, and we wear it with a badge. But it helps to be geeky around these things.
Lovingly.
Yeah, totally lovingly. But that's where it helps a little bit to remove the layers of fear. And it's not just doable. If you want this in front of you, we'll actually help you from the very moment you say go. But it's good to have sober eyes on what it means to launch a practice.
Right.
And then have a community around you that it really has your back.
You know, I often say many people launch with beer goggles. You think you're gonna build this practice and they will come. It's never that easy, and it's 13 months to get a tax ID with Medicare when you want to change something out. I mean, it's never that easy, and I understand why it's not. But having people who have done it before. I remember when I started out, Terry, and this was kind of what caused me to launch the New Hampshire Chamber, is that I had a patient who was having a mail-away pharmacy. I'm in New Hampshire. Her mail-away was in Texas. I sent the prescription to Texas, the mail-away, and they said, "Where's your supervising physician?" Like, I don't have a supervising physician. Well, I'm sorry, we can't fill this script because Texas law at that point said you need a supervising physician. So I called my friend Joan, who had been doing this for years. And I said, "What the heck do you do for people who have mailaways?" She said, "Well, tell that in Texas person to transfer the script to Ohio, because in Ohio, you're fine to practice without a supervising physician." So I called them up. I'm like, "Transfer the script to Ohio." Went to Ohio, all the scripts were filled. Same, I would have never known that. And that's simple stuff, right? But that's what happens to people is they're like, how do I work around this?
Yeah.
I don't want to tell my patient that I can't fill their scripts, right? When I opened, I couldn't sign home health orders. What did I have to do? I called it my dirty little secret. I paid a physician $500 a signature. No one knew. It was our backdoor thing. And he made a lot of money off of signing home health orders. Yeah. Because what do I tell my patient? I'm sorry, I've cared for you for your entire life. But now I can't care for you when you're in your death, dying or needing end of life care, et cetera. So it's just, you learn these workarounds, and some of them work great and some cost a lot of money, but NPs do what they have to do to take care of patients. And we shouldn't have to work that hard to provide you with the care. It's treating the paperwork. It's not changing what I'm doing with that patient. It's power, it's control, it's money.
I agree. Jonathan said something really important that struck me in all this, because I wonder how many people feel like they're by themselves. So it's what you said, Wendy, in calling up a friend to ask them what to do. It's having that community of other people who are in the same boat.
Exactly. And Dr. E runs our founders group, right, Jonathan, and meets with them, with people that are coming in or thinking of coming in. And so every month they can come together and say, what did you do? And run these things by each other, which is that's what we want.
That's what we want. And that's what the most often questions we get is, well, what did somebody else do? What can I learn from? Because even when you have a practice, like Wendy was describing, all you have is your four walls and you've got no time. You can barely pick your head up between visits. And to know that there's 4,500 or 5,000 other four-wall places around, that if you can knock down a wall and just let people ask each other and even better than ask each other, have recommendations of, oh, okay, you're doing this. You're actually eligible for a program in Medicare that they'll pay you for the outcome of your care. No one would know unless there was somebody else already doing it. And for us, that's the best value we can provide. Is just there's so much knowledge trapped in each one of these clinics. And if you can surface it to the top, the new people can have a little bit less of brain damage of getting started. And all of the existing practices, there's power in numbers. Like you as a 1,000 provider clinic, 1,000 patients, you may not be enough to satisfy some program requirement with an insurer, but 10 together with 10,000, oh, okay. Now you're for real, and now your numbers get counted. And as we've seen, when NPs compete as a group on the data and metrics that the insurances hold out, this is why it's so easy to back the group. They win.
It's so funny because Jonathan says this, but probably has no knowledge that when I used to work alongside a physician, he wouldn't show us our numbers. And Susan and I were like, we want to see our numbers. He was worried we would take those numbers and say, we want more money. We were so competitive. We wanted to show we were doing better care than him. And so I said to him, silly decision, because we're back here. We want to work harder, not because we want more money, but because we want to show this data. And that's one thing that we are doing at Duet is we have integrated our system with all of the NP practices that we support. And so we're able to pull data on, how many visits is the average NPC, right, Jonathan? And what is their breast mammogram screening rates? And we have a dashboard that we've created for these NPs that help them to close the quality gaps. So once we start working with these practices, and we have a team set up that supports these practices, we've seen mammogram orders go up. Mm-hmm. We've seen colonoscopies go up. We've seen them capture transition into care kind of visits post-hospital stay more than they ever did before. But it's also a dashboard for owners so that they can see who's the NP that's really carrying a lot of the weight in the clinic and who maybe isn't carrying a lot of weight. And it gives, and if owners say, I don't want that knowledge, then don't look at it. But you know what? In my clinic, every week, I see who's seeing the most, but who's billing out the most, and who is not. And that's going to come to play at the end of the year when we bonus out people. You better believe that those NPs that worked their butts off week after week to capture as much care as they can to make this clinic successful are going to be the ones that, if we get our quality bonuses at the end of the year and our shared savings bonuses, which we do, that's going to come back to the people who have really worked to keep this clinic sustainable.
I love that. Well, even as a practicing provider, I want to know my numbers. Where am I in the spread of everyone else? Maybe I'm seeing more complex patients, which I do, but, am I capturing something that I'm not billing that I should be billing for? I think all of these are like learning points to be better at what we're doing. I love that you guys have that.
I was going to pick up on one thing that Wendy said, and I feel like I'm telling Wendy two other things that I was going to update her. We missed our call yesterday because we were just like ships in the night. But we were on a call with an insurer the other week. Once we have a contract with an insurer, the rates for NPs get better, but all the data, around all of these performance measures of care gaps and so on, they just now get surfaced. The practice knows and the insurer knows, and it's a way of rewarding all the things that NPs are already doing. They just didn't know which button to hit in the EHR. They already do it, but they finally get credit for it. There was an insurer who was telling us it's a Medicaid insurer, and there's a new pediatric program that they're rolling out to support children in the state. They told us they have 2% compliance in the state among the big health systems because they just don't care. It's too small of an issue if you're a large health system to record the code or the associated care that you're providing to these kids in the sea of other things that you have going on, like Wendy was saying. You've got surgery centers and all that. So primary care is too small to matter. And so this insurer has 2% compliance. When we told them it's done, all these practices will do it because all they need to see is the data. They said it's the first time in the entire state where a group of practices are actually going to do the thing that are good for patients that get recorded in the system. So it really comes down to not a new muscle. You already have the muscle. It's truly just sharing information with the practice and then succeeding.
It's like flying a plane, right? If I don't know what altitude I'm at and pitch, I can't steer. So data is power. I love that you're doing that.
And you know what? I know you have learned the same way I have, and I'll never forget my faculty 33 years ago say, it is your job to contribute to the knowledge base that exists regarding NPs. That's why every year I partner with doctoral students, and they come in, they data mine my clinic, and the only reason I do it is I say you have to publish the data. So every year we get 1 to 2 publications out of NP-led clinics. What does the metric look like in our clinic? And so what I love is I will continue to do that, but Duet is now doing that. And we're starting to write articles. We just had a couple published about some of the quality that NPs are bringing to the table. So instead of just looking at claims data, we're getting real-time data on, not just submitted mammograms, but here are the mammograms that these NPs are ordering up. It's really cool stuff. And I'm excited because as the numbers of people we support grow, so too does the amount of data. And you can't just look at 250,000 patients anymore as a blip on the radar screen. That's a lot of numbers to bring that data about NP care. And these are NP-led clinics. So we're not getting physicians in this mix. We're getting the work that NPs are doing, which is great.
I love that so much. That's going to lead into a couple of my last questions. One is, at NPACE, we're really looking at our PA peers on the other side and how they really are fighting some of the same battles and doing the same care. They're about a decade or so behind us in this. What do you guys think about what's on the horizon for that and where they are in all of this business startup?
That's like you said, Terry, they're on the same path. This is the work that PAs are doing alongside NPs, which is to provide the care that nobody else is doing. I think it's almost every other person that you'll see in a clinic today is going to be an NP or a PA. But because of the regulations that surround PAs as opposed to NPs, they roll up to the medical board and NPs roll up to the nursing board. So there's a split in now NPs, I think, can practice in vast majority of the country, and PAs are only inchingly getting there. But this is a long road ahead for all of us. I mean, we're in this forever. And so to open the doors for people who want to provide great care and access and are held back for reasons that are just BS, there's a room in the tent for every clinician that just wants to have a little bit of an easier time doing this work.
And I agree. I think we're probably, Terry, I guess I would say even a couple of decades behind. And it's been so interesting because we know that NPs have been opposed by some national organizations. And to see that now happening in our physician associate colleagues as well. But as I always say, it's all about control because in many states, physician associates had to always have a supervising physician. If the physician went on vacation in this state, I don't think it's the same way anymore. And I can't speak to all the regulations on PAs because it's just not in my wheelhouse. But they had to find another physician to supervise that PA, even though we knew that these PAs almost never needed to collaborate or consult, that they were out there doing their own thing, just like NPs were doing their own thing. And it's not that we work in a silo, you know that. I've never worked in a silo. I just don't have mandated supervision or collaboration. I still collaborate every single day. I text the physician colleagues and say, hey, I'm throwing up a white flag. I need your help here. And they're always, the colleagues in my community are so gracious, so gracious. They want to see us succeed. They want us to stay independent like many of them are. They want our referrals. And you know what? All I ask is that you're courteous, you treat us well, that there's no disrespect when my patients see you. because I've encountered those things over the years as well. And I'm not afraid to call people on it and pick up the phone and say, patients are saying that you've said some things about the clinic. Is there a problem that you're having with us? Are you not getting the right paperwork from us? I have no issue doing that. I'm old. I'm crotchety. I will treat you well until I don't, because you haven't treated us well. There's one thing I just don't tolerate is disrespect. If you have an issue with us, tell me. I'll fix it, I promise you. But don't do it through patients, because patients love their NPs and they love their PAs. And so they will fight in tooth and nail. I've had patients say, don't send me back there again. I will never go back to that specialist. They were so awful and were not kind about NPs and PAs. So find me a new specialist. So absolutely. There's a lot of work we all have to do, but I'm really excited to be at the table with Jonathan, so that we can make it a doable option. And not every NP and PA is going to do this. We know that. They don't want to. I didn't even want to. And I'm not sure today if I would even go back and do it again. I mean, it's been such a great ride, but I'll tell you, I've lost a lot of sleep, particularly when I owned 2 clinics. And so, it's a hard road. And I don't know if I would do it again. No regrets. But, hindsight's 2020, I guess. It's been a hard road, but it's been so rewarding in so many other ways as well. So I think maybe 5% of NPs will do this. Some people say up to 8%, but that's a small number. It's a really small number.
It's a small number of a big number, right? Like there's 400,000 NPs now, and it's the fastest growing profession in healthcare. And so sometimes I think the numbers get confused. If 3% sounds little, and it is sounding little, but out of 400,000 people, that's 10,000 clinics. That's a lot of clinics in this country. Primary care only has 120,000 in total in the United States. So it's funny, government moves so slow compared to our individual lives where you get to make choices every day. And so we, with Wendy, decided, well, let's go work not on the government side, but on the practice side, working with insurers, because they can make decisions faster than a new law is going to get passed in Congress. So that's been our choice. And what we find is people already choose with their feet. Like Wendy's saying, they love NPs. So my brother's a physician. He goes to a PA on purpose because he knows that experience is going to be so much better. We met a surgeon at a health insurer who governs an entire wing of the entire insurer. Guess where she goes? She goes to an NP. And so the decisions that we all make are fast and a lot faster. And that's how we get to see real change happening on the ground that might be invisible or slow somewhere else. And when we started to measure the care quality at an NP clinic, because we survey every person who walks through the door, you see the numbers are better than anywhere. I mean, it's a 9.1 out of 10 across so many clinics. And that's better than the fanciest hospitals in the country. So that's where we are today, is let's go find the best, most immediate solution to remove some of these roadblocks, and then let NPs and eventually PAs just do what they love. It'll show up every single day.
I appreciate that. Oh, I think that's a beautiful note to end on. I really appreciate you being here. I've seen the work Duet is doing. I've seen it firsthand and the impact. I read your newsletters. I saw the scholarships you just did at DNPs of Color to help students. You've got the community. You've got the statistics. You're fighting the battles for people. So how do NPs find you? Where do they find Duet?
JoinDuet.com. That's it. Okay. JoinDuet.com. You can email me. You can email Wendy. It's Jonathan@JoinDuet.com or Wendy@JoinDuet.com. We can't wait to hear from you.
Oh, absolutely. And if you're thinking about it, or if you are already in it and you're in a state and you want some support, please reach out to us, because we have to get numbers to be able to move the pendulum. If we go in, I tried to go in as a 1 clinic to negotiate, hard to do, but now we have 12 or 13 or 14 in the state of New Hampshire. And we've helped 3 new clinics open in New Hampshire since we started working with them. And so those numbers translate to the ability to get in front of the movers and shakers and the decision makers. And so we would love to help anyone in any capacity. So reach out to us.
Thank you for that. I really appreciate that. This has been one of the most moving podcasts. It's such an honor for me to get to talk to people. And so thank you, Duet, for being a partner with NPACE, for being here to share all of this wisdom with the listeners. For all the listeners out there, you can find us, at npace.org. And Wendy's going to be teaching with us in 2026. We'll be together again. But we hope to continue our work with Duet. And just amplifying what you're doing and getting the information out there. So thank you so much for being here. Thanks to our audience for listening. We're going to sign off.
Oh, yes. For all of your leadership. You have been a great leader and are a great leader of NPACE, and you've taken it to great places. So thank you for being boots on the ground and picking up NPACE and running with it. So thank you.
Oh, thanks. Anything to get to advance Wright NP practice. And this is a piece of it. So I'm very lucky to do this work. Thank you, guys. We're going to sign off for now. Thanks to all the listeners. You'll join us for the end of the series. And we've got, this is going to be 5 parts. So we'll continue on. Thanks, everyone.
Thank you.